Hi, my name is Debbie Foss-Wells. I'm a registered nurse and I work as clinical nurse educator for maternal child care at Central Health. Today I'm going to be discussing safety in maternity care. So our objectives, we're going to be looking at risk management and patient safety within the healthcare system. We're going to be looking at the impact of clinical errors in the Canadian healthcare system. We're going to be talking about safety in maternity care specifically and focusing on teamwork, tools that reduce risk and errors. First, what is risk management? This is where we as an organization or a team develop strategies that will optimize patient well-being and prevent or limit patient injury. The focus is to reduce any errors that will result in significant costs related to damage, harm, discomfort, disability, or any type of distress to the patient. It also focuses on decreasing financial loss to the healthcare provider individually and the organization. There are 5 basic steps to risk management. The number 1 is identification of the risk. This is essential if you are to develop and implement any type of proactive strategy. Risk assessment is your evaluation process. Development of risk management strategies is where you develop any actions that will help decrease your risk. Implementation of risk management programs, and then evaluation of the risk management activities that you put in place. What is patient safety? Patient safety is where we try to make that patient stay in hospital free from any accidental injury. It's the state of continually working toward the avoidance, management, and treatment of unsafe acts within the healthcare system. It's where we establish operational systems and processes that decrease the likelihood of errors and increases the chance of intercepting them before they occur. What are systems? Systems are interdependent elements which interact to achieve a common aim. They may be both human and non-human. Clinical error, the problem. The Canadian Adverse Events Study in 2000 shows us that 7.5% incidence of adverse events for all admissions to Canadian hospitals. This actually plays out to mean that there are about 185,000 associated adverse events that occur. 70,000 of these are potentially preventable. And of course, with any clinical error, there's always the risk of deaths. And there were 9,250 to 23,750 preventable deaths. So why do errors occur? We know at this present time we have numerous clinical practice guidelines in place, policies, recommended procedures and standards, and excellent continuing education courses. And all of these promote evidence-based practice. However, the opinion is still that adverse events in obstetrics are inevitable. You cannot eliminate error through education and explanation alone. Humans are fallible. We expose patients and healthcare providers to risks. We do try to put defenses and safeguards in place to prevent errors from occurring, and these are divided again into human and systems. So human, we do training with our staff. We increase their knowledge base. This allows them to have better clinical judgment skills. It develops their manual dexterity, and they become more vigilant. We do promote credentialing, peer reviews, protocols, pathways and policies, special teams, continuing education, risk management, and quality management. Errors, accidents, and failures. Failures are divided into 2 different groups. There are active failures. These are unsafe acts. These are frontline level. We see immediate effects to our patients, and they result in direct harm to our patients. They are further divided into slips, which are most likely related to fatigue. Lapse, this is where you forget a step, and this is why checklists and mnemonics are very helpful. Mistakes, and an example in obstetrics of that would be misinterpretation of electric fetal heart monitoring. Procedural violation, and an example would be if you apply forceps or vacuum before full dilatation. Latent failures, these are the greatest threat to patient safety. This is where your system problem versus individual problems. Human factors, and one would be an example of multiple healthcare providers. Just in the exchange of information, handover report increases the risk of an error occurring. Workplace factors, when you have a lack of resources or when you have poor communication and teamwork. Organization factors, when we face budget cuts, staff cuts, or when there's a change in a scope of practice by a regulating body. This diagram is an example of the Swiss cheese model, which I'm sure everybody have heard, if not saw before. And this describes that while we do have defenses and safeguards in place, things can get by us and still result in patient harm. High reliability organizations, better known as HROs. These are organizations that have the ability to operate technologically complex systems without errors over long periods of time. Two examples of these industries would be your air traffic control and ATMs. We see most planes stay in the air until they intentionally want to come to the ground. When you get paid, you hope your check is going to show up in your bank account and not someone else's. So some principles of HROs: safety is their priority and everyone's responsibility. The operation should function as a team effort. Hierarchy should disappear in emergency situations. Communication is highly valued, and emergencies are rehearsed. Interprofessional review of routine functions, near misses, and unexpected events should take place. In an HRO obstetrical unit, safety-oriented culture prevails. Everyone is orientated and committed to confirming fetal and maternal well-being. Variations are decreased by standard policies and procedures. Teamwork is the hallmark of the unit, and interprofessional review of adverse outcomes and near misses take place. These would be audits, quality care reviews, and debriefings. If you look at some communication tools that are used in obstetrics and other units in healthcare, one is called cuss words. This stands for if you identify a situation that you feel is unsafe, you say you are concerned. Then you say you are uncomfortable. And then you point out that this is a safety issue. This forces the line to stop, and it encourages everybody to speak up if they identify any concerns. The next tool is the 2-challenge rule. This improves every member of the team speaking up. It increases opportunity for staff learning and sharing responsibilities for patient safety. It overcomes communication barriers within the medical hierarchy, which can improve teamwork and patient safety. This is where we do callbacks and repeat backs. So if a physician states a verbal order, you repeat it to him to make sure that you understood it correctly. Question any order that does not sound right, and it is a way of ensuring checks and balances. It empowers all team players to stop the line when they suspect or discover any essential safety breach. It is everyone's responsibility to assertively voice concern at least 2 times to ensure it has been heard. If the team member being challenged does not acknowledge, then you move on and you take a stronger course of action and go through your proper chain of command. The next tool is the SBAR communication tool. This tool is very popular now, especially in giving a handover report at change of shift or change of healthcare provider. S stands for situation. You give a clear, concise overview. B is your background information. A is your assessment, which is your clinical analysis. What is the problem? And R is your recommendations. Responsibilities of healthcare providers. Number 1, we need to identify high-risk procedures. We need to identify errors before they become adverse events. Know your limits and practice within them. Quality care review is a system failure versus individual failure. Environment for clinical error management. Be aware of local, regional, and national clinical guidelines and policy statements. There are 3 A's of quality care and risk management: ability, availability, and accessibility. Develop a culture that breaks down hierarchy, and collaboration to develop performance indicators and benchmarks for clinical activities. In summary, communication and teamwork. It's a mutual satisfying solution leading to the best outcome. It meets set goals without compromising relationships, and it is true collaboration is a process and not an event. Thank you.